Hi, my name is Dr. Jessica Stewart, and I'm an interventional radiologist at UCLA.
And my name is Lucas Cusumano. Today we're here to discuss a minimally invasive treatment for symptomatic internal hemorrhoids called hemorrhoidal artery embolization.
If you have any questions about any of the content of this video, or if you'd like to learn more, please call our interventional radiology clinic, or you can email us directly at the email addresses on the screen.
Hemorrhoidal disease is very common, affecting up to 40% of the US population. There are many risk factors for hemorrhoidal disease, including age, diet, and bowel habits.
Hemorrhoid tissue is actually present in the anus of everyone from birth. These areas are considered blood lakes with associated arteries and veins, and they're shaped like a bunch of grapes attached to the anus itself.
Hemorrhoids are either characterized as internal or external. Internal hemorrhoids line the anal canal and appear as purplish cushions, whereas external hemorrhoids are completely outside the anus.
Over time, the hemorrhoid tissue may start to increase in size, and there's increased blood flow that can occur to the vascular network in the area, causing congestion and swelling of the tissue. This enlarged tissue can then bulge outside of the anus, and bleeding can develop over time.
Hemorrhoids are graded by their degree of prolapse on a scale from 1 to 4. Grade 1 hemorrhoids have no significant prolapse, whereas grade 4 hemorrhoids are severely prolapsed and cannot be pushed back inside the anus.
For nearly all patients, conservative management is the first step in treating hemorrhoids. This includes diet modification to achieve adequate fiber and water intake, improving bowel habits, regular exercise, and avoiding medications that can cause constipation. Topical and oral medications can also be used.
For patients who fail conservative treatment, we then consider procedural options. These are characterized here by hemorrhoid grade and are all transanal.
However, the traditional first-line treatments for hemorrhoids are typically either rubber band ligation performed in the office or hemorrhoidectomy surgery. Rubber band ligation is typically the first-line treatment for grades 1 and 2 hemorrhoids. It has a good track record and works well for some patients. However, this can be painful and usually requires multiple treatments. Hemorrhoidectomy surgery is typically first-line for grade 3 or 4 hemorrhoids. It can provide a definitive solution to hemorrhoid disease. However, post-surgical pain and wound care can be issues for some patients, and the surgery requires a longer recovery time.
In the end, people continue to suffer from hemorrhoidal disease, either because they're fearful of the side effects of transanal procedures and surgery, or perhaps they are not candidates for these procedures.
Now that brings us to our treatment that we want to discuss with you today, which is called hemorrhoidal artery embolization. Embolization in general refers to the blockage of blood flow within a vessel. And embolizations have been performed by interventional radiologists for decades to stop bleeding in other parts of the body. In 2014, the same technique was first described for treating internal hemorrhoids. These receive their blood supply from the rectal arteries, so embolizing some of these vessels can reduce the blood flow to the hemorrhoids and treat bleeding symptoms.
The first step in the procedure is placing an access sheath in either the upper thigh or wrist. The entire procedure is done through this small sheath, and no large incisions are needed. A small catheter, less than 2 millimeters, is then advanced into the rectal arteries under X-ray guidance.
An angiogram is performed, such as the one seen on the screen, which refers to the injection of contrast dye through a catheter under X-ray movie guidance. This helps us make a picture of the blood vessels during the procedure.
We first perform an angiogram to identify the blood supply to the hemorrhoids, represented here by the white circle. The typical blood supply is the superior rectal artery, which is represented here by the red arrow. In a minority of patients, there could be significant blood supply from the middle rectal artery, represented here by the purple arrows.
Once the main supply to the hemorrhoids is identified, a tiny microcatheter measuring less than 1 millimeter is navigated into the rectal artery. An additional angiogram is performed at that time to confirm that the position is correct.
We then navigate this tiny microcatheter into each rectal artery branch, feeding the hemorrhoids, and we perform additional angiograms.
Once we've achieved proper position in the rectal artery, a small amount of particles and metallic coils are injected through the microcatheter until we successfully block blood flow into the hemorrhoids. Once blood flow is blocked, we confirm that this is complete by performing an additional angiogram.
We repeat embolization for each rectal artery branch. Following the procedure, we remove our catheter and sheath, and we close the pinhole access into the artery.
The procedure usually takes about 2 or 3 hours. Patients are discharged to home the same day, and there's minimal downtime after the procedure, while we do want you to avoid heavy lifting for just a few days after the procedure.
Over the next several weeks, the hemorrhoids begin to shrink in size. We expect an improvement in hemorrhoid-related symptoms, especially bleeding, during this time.
There are several advantages of hemorrhoid artery embolization compared to other procedures. This can be performed as an outpatient procedure that doesn't require admission to the hospital. It's almost completely painless and requires only a small amount of conscious sedation and local anesthetics to perform the procedure. The recovery from the procedure is rapid, and the safety profile is very good.
So how are results? Well, this is a meta-analysis of 14 studies and over 300 patients. Technical success of the procedure was 97.8%. Clinical success was 78.9%. In a subgroup analysis, patients who had embolization performed with coils and particles had rebleeding rates of about 10%. This is a technique that we perform in all our patients. Importantly, there are no cases of bowel ischemia, bowel necrosis, or other anal rectal complications seen in any of the patients.
One recent study compared hemorrhoid artery embolization to hemorrhoidectomy surgery. In the group undergoing embolization, about 86% had complete resolution of their bleeding, and about 92% in the surgery group. There is no statistical difference in symptom response between these two groups when analyzed.
However, there were several more adverse events seen in the surgical group. In the embolization group, there were 2 adverse events, only one of which was procedure-related. This was self-limiting bruising at the arterial access site. There were no evidence of any anal rectal complications seen in anyone in the embolization group. On the other hand, in the surgical group, there were a total of 8 adverse events. This included 6 patients with wound dehiscence, 1 patient with postoperative edema and an anal fissure, and 1 patient with anal stenosis requiring outpatient dilation.
This chart depicts pain over time after the first week of the treatments. You can see that the pain in the surgical group is represented here by the red line, and that it was significantly higher over this week than the post-procedural pain in the embolization group. In fact, the pain at the first bowel movement was on average a level of 6.1 out of 10 after the surgery compared to 0 out of 10 following the embolization.
Hemorrhoid artery embolization is also unique in that it is a minimally invasive treatment for hemorrhoids that is performed completely through the blood vessels. Candidates for this procedure may be patients who do not qualify for traditional therapies. Candidates for our procedure include patients who may have failed traditional therapies, are advanced age, have other medical problems, or are on blood thinners. Patients may also qualify for our procedure if they wish to avoid transanal procedures or surgery.
There are some limitations to the hemorrhoid artery embolization procedure that you should be aware of. Not every patient will improve after the procedure, and the outcome in part depends on which symptoms are the most bothersome. For example, this procedure is the most successful in treating bleeding-related symptoms. Also, grade 4 hemorrhoids are less likely to improve after the procedure. We have to be able to access the hemorrhoidal arteries in order to treat these arteries, so if you have arterial disease, this may be a limiting factor. The longer-term durability of the procedure may be limited unless additional lifestyle modifications are made. And some other pathologies, such as external hemorrhoids and anal fissures, cannot be treated with embolization.
Workup for hemorrhoidal artery embolization begins with a clinic visit and evaluation the same day. During that visit, we may administer surveys to better characterize your symptoms. We may also request a CT angiogram. This is a specialized, non-invasive imaging study to better evaluate the blood supply to your hemorrhoids. Although we perform hemorrhoidal artery embolization, we are by no means a replacement for gastroenterologists or colorectal surgeons. We rely on gastroenterologists to perform colonoscopy to screen for other causes of rectal bleeding. Gastroenterologists and colorectal surgeons could also perform traditional transanal procedures such as rubber band ligation, and colorectal surgery can perform hemorrhoidectomy. If you do not have a gastroenterologist or colorectal surgeon, we have world-class departments here at UCLA, and we're happy to refer you to one. We also work with excellent physicians in the community, and we're happy to place those referrals for you as well.
To summarize, hemorrhoid artery embolization is effective in treating internal hemorrhoids and is very safe with a low risk of ischemic complications. There's minimal recovery time required and very little pain after the procedure, which is performed on an outpatient basis. At UCLA, we offer a multidisciplinary approach to screen for other etiologies of symptoms and offer you the best treatment options.
If you have any questions about this talk or would like to learn more, please call our UCLA Interventional Radiology Clinic or email us directly on the emails on the screen. Thank you very much.
Thank you.